Welcome to the United Leukodystrophy Presents Feeding Tubes with Jackie Hain from Mayo Clinic.
Good afternoon. I wish I was with you in person like I was last year. As she said, my name is Jackie Hain, and I am a nurse practitioner. Last year when I presented, I was a member of the Division of Pediatric Surgery. Since that time, I have transferred over to a pediatric multidisciplinary clinic that works with children with respiratory, feeding, and swallowing disorders. So it's still very pertinent, and G-tubes are still kind of my passion. Today, I will be talking about feeding tubes, some of their common complications, which inevitably there are a few, and some troubleshooting. I do have a few examples. Again, it's harder to do when we're not in person, but I will show you those at the end. And if you have questions and it's a burning question that you want addressed during the talk, I'm happy to do that. Otherwise, we can do a roundup of them at the end. Next slide. I have no financial disclosures, and the photographs that I have are simply examples. I do not have any product endorsements. Next. The educational objectives for today are to discuss clinical indications for enteral feedings or tube feedings, identify various options for enteral feedings, as well as the advantages and disadvantages of each type, and to recognize potential complications related to the care with new and established gastrostomy or jejunostomy feedings. Next slide. So, oral feeding versus tube feeding. Feeding is a really important part of parenting, and it's just one small part of a child's daily cares. And I'm going to give a little disclaimer here. I live in the pediatric world, so I tend to say children and parents versus adults and people. So please forgive me if your family member is above the age of 18 and considered an adult, but I will likely use the terms parent and child throughout the presentation. People with medical complexities for whom a gastrostomy is being considered have often struggled with eating and nutrition for months or even years before coming to a decision crossroad about placing a feeding tube. Meals can be very time-consuming and exhausting for both the caregiver and the person with the feeding challenges, from preparation to feeding to ensuring that both have been done safely. A child's physical stature and nutrition status may be considered a significant reflection of a parent's nurturing capabilities. And often concession for a feeding tube placement may only happen when all the other options have been exhausted or the person's well-being is in danger. In this presentation, I will start by reviewing various definitions and devices, followed by assessment and workup, postoperative cares and common complications and management. And then I will allow time for show and tell at the end. Next slide. So some of the indications for an enteric tube placement or a tube for feeding in the leukodystrophy family include that the leukodystrophies are often a progressive disease course. And so people may be able to eat well initially, but then have a slow decline in their ability to safely eat. And really, this can be very progressive. The goal is really to have a means of safe swallowing. And some of the buzzwords around safe swallowing is called dysphagia. There are two types of dysphagia. The first is oral dysphagia, which is problems with the mouth, the lips, and the tongue and how they control the food or the liquid. The second dysphagia is pharyngeal. So that's just a little bit further back in the swallowing tube. And that is usually problems with the throat during swallowing. Dysphagia can lead to aspiration, which means the food or the liquid goes into the lungs. And chronic aspiration can cause recurrent pneumonias and damage to the lungs called bronchiectasis. Also, there needs to be close monitoring of people's weight and caloric needs. If people have sick lungs, they tend to need more calories. And also when people have more of a dystonia or are hyperreflexive, they tend to burn more calories through the day. The other thing with a feeding tube is that sometimes, especially if swallowing is difficult, medication administration can become unreliable. So if there is a feeding tube, you can have more accuracy with the dosing. Next slide. But it is not just a G tube. A lot of times when we would do consults for a feeding tube, people would say, it's just a G tube, but it is very much a family decision that people have had multiple conversations before they proceed with the placement of a feeding tube. And feeding tubes don't come scot-free. An overwhelming majority of patients do experience some type of minor complication, whether it's a skin complication or a tube being dislodged, but people have to be prepared for the inevitability of a complication. The other thing is when a feeding tube is being placed into the stomach or the small bowel through a hole in the abdominal wall, there is a change in the anatomy because it changes the angle of the stomach, and that can cause increased risk for reflux. And people who are either hypotonic or are hypertonic can have increased reflux because of this change in anatomy. Next slide, please. I'm going to briefly show you some of the feeding tubes and ways of giving feedings. Next slide. So if a temporary tube is needed, and I realize there's a typo on this slide, you can either have nasogastric, which is a tube that goes in through the nose and into the stomach, a nasojejunal or an NJ tube, where the tube goes through the nose, through the stomach, and into the small bowel. Those are used for people who do not tolerate feedings into the stomach. These tubes can be placed or replaced daily by a caregiver. If they feel comfortable, they need to be comfortable verifying where the tube is being placed. This is more tricky with children because they're less cooperative usually with a tube being placed into their nose, and both of these tubes can cause some discomfort. These are typically secured with either an adhesive securement, or in this photo, this has a bridle that keeps the tube in place, and that bridle can be kept in place for up to a month. Next slide. Something that we used very commonly in our pediatric population was the low-profile gastrostomy tube. This device sits very close to the skin, so it is discreet. It has the ability of removing the extension tubes, which go into that top flap here, so that the risk for a tube being pulled out because of the extension is decreased because the extension can actually be removed. There are several different styles and manufacturers of these types of tubes, but the basic concepts are the same. The low-profile tubes are popular, again, with the pediatric population as they fit close to the skin, which is cosmetically appealing, and it is less apt to get dislodged. These low-profile tubes are also very nice if people have airway clearance vests because, again, it sits flush to the abdominal wall. I will also address high-profile devices in a moment. But these gastrostomy tubes, this particular tube has a balloon retention device, which is filled through a port on the side. There are also non-balloon devices that have an internal bolster that secure the device in the stomach. There was a question about whether there are long-term problems with NG tubes. With an NG tube, first of all, they can be uncomfortable in the back of the throat, and especially if we're working people to have safe swallowing, sometimes people get a little reluctant to swallow when they can feel the tube in the back of their throat. Another common, well, not common, but another problem that can happen is you can have skin erosion from the tube rubbing against the nose. There's or inside the nostril. There's also the risk of sinus infections, just because that does rub against some of that upper airway anatomy. Next slide, please. These are the extensions that go into the top of that low profile device. These particular extensions photoed are 12 inches, but you can have extensions up to 24 inches. The device on the right-hand side of the screen has a little bit bigger diameter in the extension. This device is often used for venting to pull off any extra air in the stomach. The right angle device does sit closer to the abdominal wall. Next slide, please. So this high-profile gastrostomy tube is usually necessary for people with a thicker abdominal wall. The low-profile tubes come in a wide variety of sizes, including the stem length, but there is a certain extent to the length of those. And so with a high-profile tube, you have an adaptable or adjustable external bolster that can be adjusted. Again, this device does not sit close to the abdominal wall. The high-profile devices seem to me be more popular with the adult population. And you may have heard the term of PEG or PEG, PEG or PEJ. And these tubes are often placed endoscopically, meaning that it's not done with surgery, but through a procedure where a tube is placed through the stomach and then the device is pulled through the abdominal wall. Next slide, please. Occasionally, patients will not tolerate feedings that go into the stomach, and they require something called a jejunal tube feeding. This particular device in the photographs have a top. This is the low profile that have both a gastric port and a jejunal port. This has holes in the sides where a gastric feeding can either be done or medications can be administered. It has the balloon, which keeps the device in the stomach, and it has a jejunal limb which is fed into the small bowel. Again, this is for people who do not tolerate feedings into the stomach, and it goes into the small bowel. Typically, jejunal feedings need to be a continuous feeding and cannot have fast bolus feedings. Next slide. There are a variety of ways that feedings can be given. This particular photo is with a gravity syringe feeding, where the feeding is actually poured into an open syringe, and the rate of feeding can be adjusted by raising or lowering the syringe. You can also use a syringe like this with the plunger in it, and you can more easily titrate the rate of how the feeding is administered, as some people don't tolerate a really fast feeding. Next slide. There are also ways of feeding that involve a feeding kit that have a bag. The gravity feeding set has a roller clamp on it that will help you to adjust the rate of the feeding. With feedings, these typically they should not have more than 4 hours worth of feeding into the bag, just because of the risk of bacteria growing into the enteral formula or the blenderized food. A feeding set with a pump is useful when there needs to be closer titration of the rate of the feeding, or if the feeding needs to go over a longer period of time. In this photo, you'll see that there is a small pump, and these pumps are very portable. Often, patients who need continuous feedings have these small pumps in a backpack. And that way they're portable. I've had lots of patients that come in where the patient is actually walking around with the pump on their back, so that they are free to mobilize and play and do what it is that they want to do without being strapped to an IV pole. Next slide. Next slide. So with a preoperative evaluation, you really want to be looking at growth charts, and to make sure that people are staying on the growth charts. This is certainly more common in pediatric patients, but you want to make sure that people are keeping on a relatively stable trajectory with their weight. Accurate weights are very necessary. It should not be a guess. Weights should be obtained without adaptive devices, whether that's a wheelchair or if there are a lot of orthotics involved. Children with feeding difficulties from infancy are often evaluated by occupational therapy for adaptations for safe suck and swallow. Contrast studies and video swallow studies and fees evaluations help to look at the mechanism of feeding and swallowing, and help to determine if it is safe to continue to swallow. There's something called silent aspiration, where patients who have feedings that are actually going into the breathing tube, the trachea, and into the lungs don't actually cough in response to an aspiration event, hence the reason it's called silent. But silent aspiration can lead to that bronchiectasis and the lower airway disease. That's why evaluations of swallowing are very important. It's also important to get education about the feeding tube, the cares of the tube, and how to feed. Typically, again, from my pediatric surgery world, it was with a surgeon consult, but there's usually a nutrition evaluation and meeting with potentially a radiologist if it's going to be an endoscopically placed tube. Next slide. I am a firm believer that knowledge is power, that education before proceeding with a tube placement is very important, that it will help you to make the best decision for your family and your circumstance. Everybody learns in a different way, whether it's hands-on training, written materials, or videos. Here at our facility, we were able to develop a patient education video that shows all the step-by-step cares of the tube that we give to families beforehand so that they can see what they're going to be doing for themselves at home and help them to understand if this is the correct thing for them. Hospital stays, if there is a hospital stay, are usually very brief, typically 1 to 3 days. So the learning curve is very steep. So any learning that can be done before the tube is placed is certainly helpful. It's important to really think through your home situations and potential troubleshooting, such as you are out at Target and your gastrostomy tube falls out. What are you going to do? Helping families to really be forward thinking about potential scenarios is very helpful prior to hospital discharge. In the hospital, and I'll allude to this later, but because the hospital stays are very short, it's important that families are involved with the tube feeding cares while in the hospital so that they get that hands-on mentoring and experience before they go home, because they definitely will not be 100% perfect with this, but they will at least be comfortable. One of my favorite things about seeing families at the time of discharge and then when they come back at their first post-op visit was seeing how confident and comfortable families became in those 6 weeks of time where they were managing at home. Next slide. As I mentioned, hospitalizations are really quite brief. It does depend on the type of procedure that's done, whether it's a laparoscopic surgical procedure or an endoscopic placement with a tube that goes into the mouth and then into the stomach and pull through the abdominal wall. Hospital stays can be outpatient or they can be inpatient 1 to 3 days. It typically depends on how the feeding advancement is tolerated, as well as the amount of time that it's needed for education and practice with feedings, skin care and site care, and all the manual skills that are involved with providing a tube feeding, as well as pain management. Typically, the pain can be managed with over-the-counter type medications like Tylenol and ibuprofen. Patients have told me that typically it's uncomfortable for about a week. Certainly, patients that have very muscular abdominal walls tend to have more pain just because muscle has more pain than non-muscle tissue. Next slide. So with G-tube exchanges, typically the first tube change is done after 4 to 6 weeks. That allows the tube tract to mature. Typically, tubes are changed every 3 to 6 months, and most patients, after the first tube change, do their tube changes at home. Again, every 3 to 6 months, and I would say approximately 80 to 85% of patients' families feel comfortable doing the tube changes at home. It decreases the need for having to come to a clinic, and it is also important for families to be comfortable with home exchanges because if in fact, the tube accidentally is dislodged, they need to know how to manage that before they would get to a healthcare provider. With tube changes, sizing is really important. Tubes shouldn't be too tight, but they shouldn't be too long because they can get caught on clothing. So it is like the 3 bears, not too short, not too tight, just right. And I will talk more about tube sizing later in the presentation. Next slide. Skin cares with a gastrostomy are pretty minimal. Soap and water is all that is needed. Uh, Cotton tip swabs are really nice because they can get under the edges of the tube. Just as important as washing is drying because you don't want moisture underneath these silicone devices. Barrier creams are not necessary, but they are useful if there's a lot of drainage or irritation around the gastrostomy tract. Additionally, gauze or button buddies, as seen in this photo, help to provide some padding and also do absorb any drainage that might leak out of the tract. Many people, after the tube has been in place for a while, have no drainage or leakage from the tract, and they choose to not have any type of skin barrier or dressing underneath the device. It is perfectly normal for there to be drainage, or what I lovingly call tube boogers around there. Some families get very concerned if there is drainage around the tube, and it is not automatically a sign of an infection. I will be talking about leakage versus drainage later in the presentation. Next slide. So, common complications. Next slide. Usually, the common complications are tube dislodgement, which unfortunately can happen at the very worst time, like you're in the middle of a campground in Custer State Park. There can be leakage and drainage from the site. And if there is problems with how the tube fits. More commonly, the complications include skin or stoma site issues such as granulation tissue, soft tissue infections, yeast dermatitis, or a clogged tube. Next slide. It is really important that the tube does not get dislodged in the first 4 to 8 weeks after the tube is placed. The tract that is essentially the tube from inside the stomach to the outside of the abdominal wall takes about 4 to 6 weeks to mature. If the tube comes out in those early weeks, it is very possible for that tract to get disrupted. So it's important that when the tube is being replaced during that time, that it is monitored and evaluated by a healthcare provider to ensure that the tube is actually back into the stomach and not in the in-between part of the tract, as that can lead to a very bad stomach infection if feedings are not into the stomach. It does require a contrast study to confirm the placement of the replaced tube. The tract that the tube goes through, or the other word is stoma, can close very quickly. So the tube really should be replaced within 30 minutes to 1 hour. If you are unable to replace the tube, a temporizing tube like a red rubber catheter, or even I've had families use a Foley catheter to place in the tract just to keep it as a placeholder is helpful. But you do not want to use the tube until placement has been confirmed. And you do want to let the surgical team know that the tube has come out. Again, this is during those early weeks. After the first tube exchange and that track has matured, if the tube comes out, you can easily replace it and confirm placement just by venting or aspirating back gastric secretions, and that will tell you that that the tube is in the stomach and in the correct position for feeding. Next slide. So some tips to prevent dislodgement of the tube. Certainly with the low profile tubes, the risk of it being caught on something is much lower. But if the extension is in place, I have had that caught on recliner handles, crib rails, car seat handles. So if at all possible, it's best to remove the extension when it is not in use. There are ways to secure the extension if necessary, using a Velcro type of tube holder, such as in this position or in this photograph. This is an abdominal wrap called a Bennick belt that has a little hole in it, kind of like a trap door that helps to secure the tube. On the side portion here, that is Velcro that can also hold the extension in place. The other thing is that the devices that have the water-filled balloons, that water can evaporate over time. And that's just because human beings are like nice warm furnaces. And as that water evaporates, the balloon becomes smaller. If the balloon is smaller, it increases its risk for coming out. So you want to make sure that the balloon is properly inflated. Next slide. I mentioned drainage versus leakage, or those tube boogers. Drainage is discharge, usually a mucus discharge from the stoma or the tract. It is very common during the early weeks and months of tube placement because essentially we're creating a mucus tract from the stomach to the abdominal wall. Usually it's clear to yellowish green and usually odorless. Usually odor is caused by some of that drainage being mixed with some formula. If there is a change in color in the drainage to brown, that usually means that there's a little bit of old blood that is caused by granulation tissue. But monitoring the color and the amount of drainage around the tract will help you to really be able to evaluate if there is a change in the tract that might not yet be visible, such as the granulation tissue. And I will talk about granulation tissues on a coming slide. I have had it where primary care providers will often assume that because there's drainage, that there's an infection. More times than not, it is not an infection. With drainage, infections usually have a fever or pain at the gastrostomy site, or it's really warm at the gastrostomy site, redness, that it feels firm underneath there. So don't always presume that any drainage is a form of or is a sign of an infection. Again, it is extremely common during the early weeks and months of a tube being placed. Drainage can be cleaned with soap and water. Again, cotton tip swabs are very useful because you can get underneath the device. You want to make sure that you're drying thoroughly. And if there's a lot of drainage, you can either use like the Button Buddy or the gauze dressing. And if that moisture is irritating to the skin, to use a zinc oxide barrier cream. You want to use zinc oxide rather than like a petroleum-based barrier, that's because petroleum-based barrier creams can be I want to say the word harmful, but it is hard on the silicone device itself. There was a question that came in about how often do you recommend checking the water in the balloon? That varies by the manufacturer, but over the 800 gastrostomy tubes that were placed during my years in pediatric surgery, I have found that by checking the fill volume once to twice a month is usually sufficient. You don't want to do it more often because taking the water out of the balloon to see how much is actually in there and then refilling it, if you do that on a regular basis, that can actually weaken the balloon. I recommend checking it on the 1st and the 15th of every month because there's a 1st and a 15th to every month. And that also helps to prevent that untimely dislodgement of a tube. The other thing is if you notice that the tube seems unusually loose, you should check the fill volume in there because these balloons are man-made and they can get holes in them. And usually the first sign is that how the tube fits seems a little bit looser. So if you suspect that there could be something wrong with the tube, I would definitely recommend checking the fill volume, filling it to the appropriate amount, which is based on the manufacturer, and then checking it again like 3 or 4 hours later, because if there's a slow leak in it, that let's say 4 mLs that was in there when you replaced it is likely going to be down to 2 within a couple of hours. Then you know that you need to replace your tube. Next slide, please. So the brother to drainage is leakage, and leakage is actually the leakage of either gastric secretions or formula or your enteral feeding out of the tract. That is most commonly caused because the balloon is not fully inflated. That inflated balloon helps to secure up against the stomach wall, and that is what helps to decrease the potential for leakage. You do want to make sure that you have that adequate fill volume, and you also don't want to overfill the balloon. Excuse me. Most of these devices will tell you how much water should be in the balloon. If it is leaking, you want to figure out why it's leaking. First, check the balloon. But if someone has very poor motility and feedings are not going downstream, if someone has constipation, that can be another cause of leakage simply because the formula is going to find the path of least resistance to come out, and constipation can certainly cause some difficulty in the feedings being absorbed. If there is leakage from within the device, meaning it's coming out the top when you're hooking up your extension, it could be because there is not proper seating or that the extension is not properly locked into the device. It can be because there are anti-reflux valves, especially on the low-profile devices, and sometimes medications that are sticky can cause those anti-reflux valves to stick open. So you want to clean those with a cotton tip swab and some water, and you want to make sure that there isn't anything on the extension that's getting hung up when you're trying to seed that extension. And it might also be that if there's a lot of gastric pressure, like there's a lot of distension or bloating, that again, the feeding is going through the path of least resistance. So you may need to be venting your gastrostomy tube more regularly. Next slide. So you can see the difference between the drainage, which is the kind of yellowish brown drainage around the gastrostomy tube, and leakage in the other photo where it's actually dripping down the abdominal wall. You can see the photograph in the photograph of drainage. That is granulation tissue. That is the #1 cause for that drainage to appear. Next slide. I mentioned tube sizing earlier. So one of my mottos is we're all skinny when we lay down. That's why we put on our tight jeans when laying down on the bed. But we are thinner when we lay down. When we sit up, we tend to have a few more tissue rolls, and how a tube fits when a person is seated is very different than how it is when they're laying down. So a tube might look like it fits really well when they're laying down, but when a person is sitting up, the tube is causing pressure points on the abdominal wall. But it can also cause the balloon or the bumper on the internal part of the device to be pulled up snug against the gastric wall, and that can cause granulation tissue within the stomach. It can cause erosion or something called buried bumper. None of those are favorable in terms of comfort, and so that's why you want to make sure that the tube fits properly. Poor fit can cause leaking as well, the granulation tissue, and skin breakdown. One story I often tell is that I had a patient that had a gastrostomy tube placed when he was about 7 months old, and he had a G tube that the stem length was 1.7 centimeters. When he was 17 years old, he presented back to the clinic, and that gastrostomy tube had not been upsized, and he had a lot of skin issues and leakage because the tube wasn't appropriately upsized as he was growing. In this particular device, this tube sizer actually has little numbers on there that tells us what size the tube should be. This device is inserted into the tract once the G tube is removed. The balloon is filled, and then the blue disc is slid down to the abdominal wall, and the patient is put into the proper position, and the numbers will tell how long of a stem should be placed or should be used on the gastrostomy tube. Next slide. So the dreaded granulation tissue. This is likely the most common complication. We see it in 40 to 50% of all patients. It's very common during the early healing phases. However, it can occur at any time. It can often happen because of a traumatic removal of the tube, like it gets pulled out with a fully inflated balloon. It typically is either pink or beefy red, and it's moist, and you will often notice a lot of that drainage. In the previous photo, from the granulation tissue. Often the tissue will start within the tract itself. So it's kind of like a rabbit poking its head out of its home. And so it may not be there when you go to bed at night, and the next morning you may see this tissue growth. Often families are alarmed when they see that because they think the stomach is coming out of the hole. I have actually only seen a gastric prolapse on less than a handful of occasions in 15 years. It is usually granulation tissue, and it can be easily treated. Next slide. Ways to treat granulation tissue. #1, prevention, making sure that the tube fits properly and that you have minimized your risk for an accidental dislodgement with a filled balloon. In this particular photo, you can see that there is kind of a gray discoloration of the granulation tissue. This tissue has been treated with a silver nitrate applicator. That can be a little bit uncomfortable. Patients have told me that it feels like a bee sting that usually lasts about 10 minutes. Usually this is done in a physician office, at least for the first couple of times, just to make sure that it is truly granulation tissue that is being seen. But if a person really has recurrent granulation tissue, I have had families treat it with silver nitrate at home. You want to make sure that you're using a barrier cream around the gastrostomy site on the healthy tissue to make sure that you're protecting that surrounding tissue from any potential drainage or leakage from the treatment that you are using. There is a commercial product called Granulation that is a topical lotion that is applied to the granulation tissue itself, and that has been very useful for many patients. That is not a prescription, and again, can be purchased online. Me salt dressings are actually a hypertonic saline or a high saline content dressing that helps to dehydrate the tissue. Aquacell dressings can be used just to decrease the amount of um, moisture around the tube. Topical steroids can be used on the granulation tissue. With topical steroids, again, you want to be protecting the healthy skin, and you typically want to cycle the use of that 10 days on, 5 days off to prevent thinning of the surrounding skin. Another homeopathic treatment that I have used and with quite a bit of success is alum powder, which can be found in the spice aisle at your grocery store. You can either create a slurry out of that or apply the powder directly to the granulation tissue. And again, that does help to essentially dehydrate the tissue. Next slide. I'm going to go to a quick question here that asked about, does tube sizing work the same way with a mushroom? So with the mushroom type devices, those typically have to be changed in a healthcare provider's office. And usually sizing is done by your healthcare provider. It's typically not done at home because the healthcare provider has to write the prescriptions for your home enteral supplies, and that way we can adjust any sizing on there. So with the mushroom devices, they usually have to be removed in a healthcare provider's office. And again, that sizer is only used in the tract once the device is removed. Good question. On to soft tissue infections. These are most common in the early weeks after a tube is placed. It can happen more often in patients that have an immune compromise, such as our oncology patients. Typically, as I had mentioned earlier, you can see the redness. If you were to feel this, this would often feel warm. It may feel firm, or it might actually feel kind of fluctuant, kind of like how a waterbed feels. Again, this is relatively uncommon in the post-operative stages. More commonly, there may be a suture granuloma because depending on the technique that is used for tube placement, driving sutures are being placed to help secure the stomach wall up to the abdominal wall. And as that suture is breaking down, that can cause a small local infection that can usually be treated with a topical antibiotic and debridement. Otherwise, it may need a short course of antibiotics. Next slide. Yeast dermatitis is usually caused by a excessive moisture around the tube, usually due to leakage or the drainage. It's similar to like the yeast dermatitis that babies can get or people can get with wearing diapers, and there isn't a lot of good airflow. You want to use a topical antifungal like nystatin, whether it's powder or cream. You want to make sure that they're not occlusive dressings, and you can use like a calcium alginate around the insertion site, which again keeps the site dry. Next slide. Clogged tubes are often very problematic because if you can't get it unclogged, you need to get the tube exchanged. There are a few products on the market, like a clog zapper, that's essentially like Drano for a gastrostomy tube. Those are available online, but most of the time, if you can prevent the tube from getting clogged, you're not going to have to go down that trail. Usually it can be prevented by flushing frequently. You should be flushing tubes with warm or room temperature water, not cold water, especially if you're flushing between medications, because that can coagulate or thicken anything that might be in the stuck in the tube. You want to be, when you're flushing, say between medications or during feedings, you want to make sure that you're using the amount that's appropriate for the patient, especially if they need water flushes to maintain hydration. But typically, if you're giving, say, 5 medications, you could use about 5 mLs between each medication to ensure that it has fully cleared the tube before you give the next medication. You want to make sure you just have enough to flush from end to end of the tube, whether it's an NG tube or a gastrostomy tube with an extension. If you're giving medications, you want to, if appropriate with the medication, dilute it a little bit if it is a liquid medication, just so it's not quite so thick. And then again, flush after the med is given. If you have medications that need to be crushed, you need to make sure that you crush them very well. You cannot give enteric coated medications through a gastrostomy tube because that coating will definitely clog a tube, and I have learned that the hard way. You don't want to mix any medications together, as they might precipitate or have an interaction with each other that might cause the tube to clog. If a tube is clogged, you want to use a syringe of the warmest water you can tolerate, kind of like if you're testing a bottle for the warmth, to make sure, just in case that it splatters, that somebody does not get a burn. And you want to then use a push-pull motion to try to loosen the clog. You can go online and find all different recipes that people have used, like using meat tenderizer or Coke or cranberry juice, and all of those can potentially cause issues with more clogging of the tube, especially if you don't know how it's going to interact with whatever caused the clog. And if necessary and you can't get the tube unclogged, you may require a tube replacement. Next slide. My take-home points are that parents and caregivers become the experts with the gastrostomy tube. Oftentimes, if you are to present to an emergency room, the care provider is the expert and knows far more than the medical provider about gastrostomy tubes. Most gastrostomy tube complications are minor and can either be handled by yourself at home or with your primary care provider. And just probably the most important point is that enteral feeding can dramatically improve the quality of life and health for both the patient, child, and the care provider. I have I have one more question here, and then feel free to load in any questions that you might have. I know this is a lot of information in a 45-minute time span. I will also be available offline. And Tara, if you want to get to the last slide, that will have my email address. So if people want to use that, they can. The very last slide has my email on it. There was a question about, can you briefly discuss the difference between a balloon versus a mushroom? So a mushroom is essentially a non-balloon bolster. The bolsters that keep a G-tube in the stomach can either be a balloon or a non-balloon device. The non-balloon come in different types. One actually does look more like a mushroom. Some of them look like a disc that is not very flexible and requires traction for removal. The non-balloon devices tend to require medical care for the exchange. They tend to not have to be exchanged quite as often because you don't have to worry about the integrity of the balloon that's filled with water without it getting a hole in it, or it's less impervious to the gastric secretions and acids that are in the stomach. There are some devices that have the mushroom or the internal non-balloon bolster that can last up to a year. The important part about that is making sure that as things are as time goes on, that the tube fits properly and that you're not having any malfunctions. I would submit that 6 months to a year is about the extent of any life on a gastrostomy tube, just because of the exposure to the gastric secretions. I am going to go to live comments to see if there are anything else. Right now, there are no other questions online, but I will stay online for these last 2 minutes. Certainly, if you do have more questions, because I could talk about G-tubes for 2 hours if you let me, and I would like to tailor any questions that you might have. So feel free to shoot me an email. I will be on vacation the next couple of weeks, so if I don't get back to you in a timely fashion, please understand, but I will get back to you at my earliest opportunity. Oh, I was going to show you tubes and I failed to do that. So I do not have a non-balloon device, but this is a balloon device. This is the balloon port. I am not putting water in it, but you can see that as there's less water or less air in this particular device, the balloon gets much smaller. So if there is that evaporation of water in the balloon, that increases your risk for the tube to fall out. This is how the extensions work. And then the feeding comes through the hole at the bottom of the device. These lock into place and are removed by turning it the opposite direction. This is a GJ tube. That has the balloon and the jejunal extension with a hole at the bottom, which allows the feedings to go there with gastric ports right above the balloon. There is one last question here. Suggestions for gas and burping. The tube can be used for venting just by using a syringe and either the plunger or opening up the syringe, and the air can be expelled that way. One last question here. There's a lot of drainage requiring gauze pads. I would evaluate how the tube fits. Again, if there is granulation tissue in the tract, that might be causing the ongoing issue with the drainage. Otherwise, if it is leakage, again, you want to check how the tube fits and that the balloon is properly inflated. I am out of time. Thank you so much. Appreciate you all joining me.